A 70-year-old man is admitted to the hospital from a nursing home with a severe pneumonia. He was discharged from the hospital 1 week ago after open heart surgery. The patient has no known allergies. Which of the following regimen is most appropriate for empiric coverage of methicillin-resistant Staphylococcus aureus and Pseudomonas aeruginosa in this patient? The options given are vancomycin plus cefepime plus ciprofloxacin. Option B, vancomycin plus cefazolin plus ciprofloxacin. Option C, telavancin plus cefepime plus ciprofloxacin. Option D, daptomycin plus cefepime plus ciprofloxacin. What is the most appropriate regimen for this patient? First, how to approach this patient? Look here, this patient is having age by 70 and this patient was admitted with the problem of severe pneumonia. That's first point. And this patient has had previous history of open heart surgery 1 week back. So it's a cardiac patient. There's no history of any drug allergies. Okay. And for this patient, they're asking what is the most appropriate empirical treatment for MRSA and for treatment of Pseudomonas infection. This is the question. To approach this question, look here. Look at the option cefepime, cefazolin, cefepime, cefepime. That means for Pseudomonas infection, we can use cephalosporin. Among the cephalosporin, cefepime is very important drug. Then cephalosporin important drug, and one more drug, ceftazidime. All these are important. Cephalosporin useful for Pseudomonas infection. Among the quinolone, ciprofloxacin and levofloxacin are useful for Pseudomonas infection. That means when you talk about Pseudomonas infection, cefepime useful. Cephalosporin, a first generic cephalosporin that is not having role in Pseudomonas infection. That means this option is ruled out. So the right answer may be option A or option C or option D. Now look at this. This patient is having MRSA. For treatment of MRSA, we can go for a glycopeptide group of antibiotic like vancomycin, or we can go for telavancin. Or for treatment of MRSA, VRSA, we have one drug called daptomycin. So option A or C or D can be useful. But the point is, this patient is having severe pneumonia. In pneumonia cases, if we use daptomycin, a lipopeptide antibiotic, may be inactivated by surfactant. So, daptomycin not useful for lung infection like pneumonia, because in the lung it is getting inactivated by surfactant. So, in severe pneumonia cases, this is not good. So, this is also ruled out. Now we have only A or C option. Now look at this. This patient is having previous history of open heart surgery 1 week back. In a cardiac patient, be careful. Telavancin may have the risk of causing QT prolongation. That too when you give along with any macrolide antibiotic or with quinolone like ciprofloxacin. Look here. The ciprofloxacin having microsomal enzyme inhibitory action. Because of having microsomal enzyme inhibitory action, it may increase the plasma level of telavancin. So this may have risk of causing QT prolongation. So in a cardiac patient, this is not a good option. So this is also ruled out. So the right appropriate answer for the question will be vancomycin plus cefepime ciprofloxacin. That's the right answer for this question. Here, for MRSA, we can use vancomycin. For Pseudomonas, we can use cefepime and ciprofloxacin. So the most appropriate answer for this question will be option number A. Now, I have one more thing for you, that is For treatment of MRSA, what are all the drugs we have? And for MRSA, VRSA, what are the common antibiotics we are using? And then we have put antimicrobial drugs useful for Pseudomonas infection. These three things I'm going to give extra for you. For example, look, normally for treatment of methicillin-resistant Staphylococcus aureus infection, we go for glycopeptide antibiotic as a drug of choice. For example, the most important drug of choice for MRSA infection will be vancomycin. It's a glycopeptide antibiotic. But all of you know that this drug may cause side effect of red man syndrome. Due to histamine releasing property, it causes red man syndrome. And vancomycin also causes nephrotoxicity and ototoxicity. And for completion purpose, you should know what are all the other glycopeptide antibiotic useful for MRSA. That includes teicoplanin, oritavancin, telavancin, and dalbavancin. All these are other glycopeptide antibiotic useful for MRSA. Here extra point, teicoplanin having least amount of histamine releasing property, so less risk of causing Redman syndrome. Oritavancin, no need to modify dose in kidney failure. All other glycopeptide needs dosage adjustment in kidney failure. Telavancin also nephrotoxic, extra point. It may cause QT prolongation, especially when it's given along with microsomal enzyme inhibitor. When you give telavancin with microsomal enzyme inhibitors like ciprofloxacin or macrolide antibiotic like erythromycin, then there is a risk of causing QT prolongation. Dalbavancin, a glycopeptide drug having longer duration action. Single dose acting for about 6 to 10 days. That's what drugs useful for MRSA. Other than this glycopeptide, you should know fifth generation cephalosporin. Fifth generation cephalosporin like ceftobiprole and ceftaroline. They also useful for MRSA and they also useful for community acquired pneumonia. The finishes antimicrobial useful for MRSA. But now, vancomycin also developing resistant we call VRSA. So, what are all the important drugs we have for treatment of both MRSA and VRSA? For covering both MRSA and VRSA, we have number one, linezolid, the antibiotic acting by inhibiting protein synthesis. Another streptogramine. It is also an antibiotic acting by inhibiting protein synthesis. Yeah, another very important drug useful for MRSA VRS is daptomycin. It is actually a lipopeptide group of antibiotic. This drug also useful for MRSA VRSA. And finally, we have TG-cycline. It's one of the tetracycline given intravenously. So, intravenously given tetracycline, it is also useful for MRSA, VRSA. That finishes antimicrobial useful for MRSA, VRSA. And then a small word about drugs useful for Pseudomonas infection. Okay. Pseudomonas infection. For this, there are so many antimicrobial drugs useful. For example, among the penicillin group of drug, we have something called carboxypenicillin like carbenicillin and ticarcillin, uridopenicillin like acetylocillin, piperacillin, meslocillin. These are the penicillin group of drug useful for Pseudomonas. Even cephalosporin also useful for Pseudomonas. Among the cephalosporin, the most important cephalosporin useful for Pseudomonas infections are number one, ceftazidime, cefoperazone, and cefepime. All these are very important cephalosporin useful for Pseudomonas. And then there are some aminoglycoside antibiotic also useful for Pseudomonas. For example, we have tobramycin, amikacin, and gentamicin. These are aminoglycosides useful for Pseudomonas infection. And then atypical beta-lactam antibiotic like carbapenem group, imipenem, monobactam, aztreonam useful for Pseudomonas. And then quinolone like ciprofloxacin, levofloxacin useful for Pseudomonas. And then polypeptide antibiotic like polymyxin B and polymyxin E. The polymyxin E is also called colistin. Now, one more very interesting point, doctor. When you want to have a very good coverage on Pseudomonas infection, better go for combination of beta-lactam antibiotic. That is, penicillin and cephalosporins are beta-lactam antibiotic. So, for better efficacy, give beta-lactam antibiotic along with aminoglycoside drugs. So combination of beta-lactam antibiotic with aminoglycoside produces synergistic action. So in case of severe Pseudomonas infection, to have a wonderful effect, better go for any one of the cephalosporin plus any one of the aminoglycoside. When you give combination, that have better action. And if the organism resistant to all drug mean, the last option will be colistin. Colistin is a reserved drug useful only for resistant cases of Pseudomonas infection. So in this question, you should know what are all the antimicrobial drugs useful for MRSA and drug useful for MRSA, VRSA, and then drugs useful for Pseudomonas infection. Finally, a small word, telavancin along with the microsomal inhibitor may have risk of causing QT prolongation. Daptomycin may be inactivated by pulmonary surfactant, so not useful for pneumonia. That's a key point for this question. Okay, all the best. Thank you.
Mrs. X is a 50-year-old obese female who has had type 2 diabetes for the past 10 years. She is currently being treated with metformin, but her HbA1c is above the normal level. She has a history of heart failure and chronic obstructive pulmonary disorder. Her physician would like to add a medication that will not cause any weight gain. Which of the following would be the most appropriate to control HbA1c in this patient? Option given are linagliptin, glimepiride, pioglitazone and inhaled insulin. Now how to go through this question? Okay, there is a obese patient and type 2 diabetes. We know obesity with the type 2 diabetes mean the first line drug of choice is metformin. So she was on metformin. But the HbA1c is not under control, so she need a additional therapy. But she having history of heart failure. Okay, when the patient having heart failure, we cannot use pioglitazone. Pioglitazone on chronic therapy may cause congestive cardiac failure that is not good for this patient. And this patient having chronic obstructive pulmonary disorder. That means inhalable insulin cannot be choice for this case because inhalable insulin may cause bronchospasm, bronchitis, so it is not a good option. And her physician would like to add a medication that will not cause weight gain. So only two options left out, and which is not causing weight gain. Glimepiride is sulfonylurea causing insulin secretion. The two important adverse effects of glimepirides are hypoglycemia and weight gain. So this is also ruled out. So the only one option is linagliptin. Linagliptin, a DPP4 inhibitor. DPP4 inhibitor in general weight neutral, neither increase weight or nor decrease weight. They are weight neutral. So for this patient, a appropriate medication may be linagliptin. That's the answer for the question. But again, one more point, doctor. You should know one extra point. What are the anti-diabetic drug causing weight gain which are causing weight loss. That's also an important area for MC question. So you should know anti-diabetic drug causing weight gain. Weight gain are insulin and insulin secretagogue. Insulin secretagogue like sulfonylureas, meglitinides. Insulin, sulfonylurea, meglitide. And one more thing, thiazolidinedione, the so-called pioglitazone, that also causing weight gain because of fluid retention. Whereas weight loss mean think of pramlintide, GLP-1 analog and AGLT2 inhibitor. Here most important, GLP-1 analog causing weight loss. Among the GLP-1 analog, we have one drug called liraglutide. It was FDA approved drug for treatment of obesity. And SGLT2 blocker also having weight loss property. And finally, weight neutral. Among the anti-diabetic drug, DPP4 inhibitor, the so-called gliptins and metformin are comes under weight neutral. But practically speaking, metformin may cause mild weight reduction. But clinical research shows metformin nowadays comes under weight neutral category. So you should know anti-diabetic causing weight gain, weight loss, and weight neutral. That's also important.